the superior surface of the middle canal fossa floor, and the posterior surface of the anterior into the posterior fossa, and the anterior and inferior components play the roles for the attachments of the neck and intratemporal fossa, and the lateral part attaches with the muscular and some cutaneous part of the head. So just simple for Victoria demonstration you can understand. The pink color, this is the floor of the fossa, and this is the superior surface of the temporal you see from the inside. And the antral limit, this is the posterior canal fossa, you can see again the pink color, it is the antral limit of the posterior fossa. So again you already mentioned the inferior and anterior face, there is the attachment of the some muscles, and this is the very common, easily visible side the lateral part by some muscles and some fibers structures are attached. So this is the lateral surface of the temporal bone. You see. This is the lateral surface. There are some important landmarks which we must know. One is the suprametal spine or spinal handle. That is, we all know the surgical landmark of the nostril and cubiform area. Here is the cubiform area through which some small vessels communicates to the nostril entrance to cortex, and we all know the role of these vessels. There is a migration of infections from the nostril to the cortex in case of this area. And there are two important suture. There is the one is the temporal muscular suture. There is the temporal muscular suture contain the ulnar nerves and nerves of the vagus nerve. And the petrodical, there is one difficult area usually not seen actually, not seen. Mostly theoretical. There is the petrodical fissure or glycerial fissure contains the canal of Fugia for the anterotiperic artery and the quadriperic nerve. That is the exit point of the quadriperic nerve and the blood vessels of the nerve. And the common largest area we encountered at the elevation of the posterior muscular facial flap. If we go a little bit posterior, there is a muscular foramen exits the initial vein and from the cortex to the plantar sinus, and it also transmits the branch of the occipital artery to the branch of the external vein. So this is the articulated form of the temporal bone. You can appreciate the articulated form of the temporal in the lateral thoracic place. And again the middle fossa surface, one of the again the very complicated part, not easily seen, only by dissections and some anatomy you can just understand. In the armpit eminence, you all know there is the prominence of the suprasemicircular canal and hiatus of the facial nerve. In this vein there are some canals, impressions of some important structures. There is only the genicular tendon, metasuprotectional nerve, supratemporal branch of the middle phalangeal artery, and supratympanic canalicularis. If you can understand, there are some impressions here. The supratympanic canalicularis located in the pectotympanic pectoralis fissure contains the laser supratympanic pectoral nerve, transmits the supratympanic artery. In our surface anatomy and gross anatomy, we have learned these things in variable part of our life, but in temporal bone dissection, we are now focused on some important components. Again, this is a very important component. You all know the posterior fossa, the interrotatory canal, which transmits the facial nerve, caustic nerve, and the lemniscate artery. There is the important structure of the subaqueous fossa, transmits the subaqueous artery, parts of the lemniscate artery, and apparatus of vestibular aqueduct lies in the fovea impressions covered by the operculum, and it loses the umbilical dark inside. And this is the inferior view, one of the very complex view. The outside some part is easily visible. There is digestive hook to hook. It loses the digestive muscles. and the jugular-carotid is fine. There is a part, the partition between the carotid and the jugular, and erosion of it indicates some jugular prolongation. The tympanic canalicula's which contains the one of the commonest nerve, the tympanic nerves of the glosopharyngeal nerve and infratympanic artery, and the cochlear canalicula's contains the periaortic duct between the tympanic canal and the submarine. That is the you all know the communication between the skeletal between the submarine space. And this telemotion phenomena translating the facial nerve and skeletal nerve. So it is very separately it has been shown. This is one of the parts of is in the same. The jugular portion carotid canal. So you know this is the carotid canal, this is jugular portion. And again the inferior view. So this is the impression. There are so many cells in the mastoid, and this is the actually main component through which we dissect, we find out all the vital structures. And according to the variations, and all cells are not same way developing all the parts. So following these cells, we actually dissect, we proceed our dissections, and we find out our vital structure. Our target of the dissection is to just dissect the cells, keeping all the vital structures preserved. There are bones or vessels or nerve. So this is just for impressions. You all know the ISC. There is a transvascular, the Beals bar. There are two. So this is the Beals for the fisher nerve and the superior, and the cochlear nerve, posterior superior vestibular nerve, and one more very fine nerve in this canal is the singular nerve. So again, it is for impression. So I put some important lines. One line is like Professor Tsunaki Ulu. He has a very nice he's from Karnataka. I met him in 2013 at France. He has some good comments. First, the good surgery. First, identify the correct procedure. Second, adopt the good surgical technique. Third, achieve a short operating time. Keep it in mind. Hurriedly doing surgery by escaping the good quality surgery is not acceptable. Someone tries to show he has finished the surgery within 1 hour, half an hour, but it is not acceptable. If you proceed, follow a correct procedure and adopt the surgical technique, you can do your surgery within a short period of time. So this is a very important question. So the concepts are good surgery again, the precise knowledge of the surgical anatomy, the precise knowledge of the surgical theory, and precise control of microscope drills and the microsurgical instruments. And aims of our temporal dissection is to simultaneously medullary surgery in a laboratory setting. That means we want to practice everything in a temporal bone that we can just follow, we can do in the live surgery. So if we elaborate the objectives, our target is to use the same surgical setup as theatre for realistic practice. So we try to accommodate you, provide you the instruments, microscopes, drills. Same thing you can apply in your lab surgery. Develop surgical skills in a safe and controlled environment. Recognize and understand the anatomical variations. Ultimate target is to build up with confidence before operating on a live patients. So for the dissections, we need some minimum instruments like that, the good quality operating microscope, micromotor with diamond and cutting various sizes of parts, the suction tubes and irrigation tubes with different sizes, surgical knives, tissue dissectors, microsurgery scissors, periosteal millimeter, fluid elevator, sickle knife, straight and angle, round elevator, needle and curette. These are the basic instruments we must need. So one of the first important instrument we need a good quality microscope that should be balanced and easily movable. Sometimes microscopes there are different knobs. You forget to loose and fit. Sometimes it should not be too loose. It should not be too tight. It will be balanced condition so that you can manage it very nicely. And check for the binocular vision. Means you want to see the object with the two eyes, and you adjust your IPD for correct focusing. And start with the higher magnification, lower magnification. First, start with the lower magnification, and higher magnification especially needed for focused, very pointed areas like that. If you want to see a foot plate, some component of the vessel or nerve, so only then you can use your focus, because if you magnify higher, the ceramic field will be shorter, so you cannot correlate with the ceramic structures. And finally, the light, you should not be very too light or low light, the optimum light, so that you can see it better, to avoid the glare. And you keep it in mind, the microsurgery we do the millimeters or millimeters. So without focusing the precise way, you will miss some vital part and you will fail to reach your target point. And there will be some trauma if you can handle your instrument in a very fine focus area. So now come to the drilling technique. The drilling technique prior to actual bone work, the testing of the drill is required. The drill must be securely fixed to the handpiece. Someone starts the drilling, the bar is not tight, so there will be injury to the surrounding structures. Hold the drill piece as close possible rotating shape of the bar for maximum control. And adjusting the stability is achieved by anchoring the fourth and or fifth finger to adjust it. So you will hold some other part to the adjustment structures to get the control of your handpiece. Hand should not be float. It should never be float. It should be always supported. The largest possible bar should be used, and small bars are always very dangerous, and it should be used very controlled way, in a very small, targeted area, in a very controlled way. Adjust the length of the bar according to the depth of the area. If you need to deeper part, you need a shorter, longer shape area. If you do work on the surface, the bar shape should be shorter. Adjust the length of the bar and the depth of the area to be drilled. In general, the shorter bar, better control. And most of the time we need actually shorter bar. The most bone work is done using the cutting bar, but in some delicate structures, diamonds are reserved for working near some delicate structures such as the facial nerve, dura, sigmoid sinus, for stopping bleeding originated from the bone. Hold the drill like a pen and always try to make the direction perpendicular to the structures you are drilling, so that the drilling is carried out side to side rather than deep. So main conception, the drill should be used with the side of the bar, not the tip of the bar. So you will not do the trauma to the structures. And you should never, sometimes our bars are not sharply cut, the older bar. We try to deal with the pressure. It is totally unacceptable. If you do pressure over the structures, you will do trauma. So you need to drill, cut the underlying structure with a minimum pressure to avoid the underlying damage to the underlying structures. So in delicate work, near important structures, the direction of the rotation can be adjusted so that the bar rotates away from the structure rather than towards it. Like that, it is our common dictum. If we want to drill towards the master diaphragm, our dictum is to always drill away from the, that is medial to lateral. You drill like, not like this. It is away. So you always try to start drilling vital structures to outwards, not towards vital structures. Continuous irrigation removes the bone dust and connective tissue from the drill area and avoids thermal damage. We all know the role of the irrigation. We all know it makes the fields clear as well as reduce the hits what the damage to the underlying structures. And beware of all interactions between your bar and the anatomy. Other bony surfaces may be unintentional drill. So when you will, the target of the bar to be selected so that does not touch the surrounding structures. It's only touch to, you want to go for drilling towards the address to entram. You are not allowed to touch the dome of the lateral semicircular. You are not allowed to touch the tagline. Your target is to reach some bones to get access to the address terminal. So keep it in mind. Optimize your portion. This is very important. If you don't drill, sit in a comfortable position, you will be tired in a point, you will be back pain, you will be shoulder pain, you will be, so this is very important. And you see the simple picture, what happens in our drilling most of the time, you see the direction should be very smooth rotation. But most of the times, when you start drilling, the bar jumps, jerking over. This is not allowed. It should be smooth, it should be like that, because we all know we are using actually the general drill, and the shape of the bar doesn't be shorter, what we mentioned, because of this limitation of the drill. So, in the other hand, sometimes we see the bar may be carved or bar may be older, so it is not well fitted. So when you start drilling, you will see it is like this, but it should be like this or it should be like this. So this is very important. If it is happens, the skipping movement is not allowed. So preparation and planning makes you are sitting comfortably. Uncomfortable seat is called rather unnecessary discomfort. Let your hands rest. I have already mentioned. Hands are more stable and delicate manipulations are easier. Safety procedure: gloves, gowns, and eye protections are strongly recommended. Remove connective tissue from the temporal and fix the clean bone in a holder position similar to the normal surgical position. So, sir, so one of the very important components, though, that is the if you cannot clean your bone perfectly, if you don't remove the soft tissue thoroughly, you cannot dissect it well. One of the most of the time we see that dissector starts drilling, keeping all the tissues around. You clean everything from the temporal surface so that you can drill comfortable. So I just show some. This is the standard anatomical position where you will hold the bone in a holder, and it should be like that. The master process will be no doubt. This is the position. It should not be this but this. So you can drill comfortably, and you can achieve, you can simulate your real surgical position. We see that the initial drilling we uses I just show some some areas. Formal drilling, formal drilling. So we sometimes starts the drilling in the supramuscular test, and you see always you try to drill around the vital structures with largest cutting part with copious irrigation. Like this, if you drill at the area of the sequence area, you will drill in this area, not like this. And all possible, all time possibly you will try to use the largest cutting part. So again, it will be shown and sharp in the section. I just give you impression in some vital structure when you go for drilling towards the dural area or sequence sinus area. So there you must use the time that is the time. Again, same when you reach sequence sinus area. So what I mentioned earlier, when you will reach towards the master antrum, your rotation to be always away from the underlying vital structures, not towards. So this is one important point I showed. You see the underlying this the market. That is one of the vital structure. That is the short process of incus. So you must be careful. You need to delineate the incus to reach to see something. In the industrial term or posterior term, or if we go for the posterior term. So there
1 millimeter part.
We should always be careful, not touching the part to the ossicle. Sir mentioned yesterday, if you touch the bar to the ossicles, there may be some commonly there may be a possibility of sensory hearing loss, or even there may be a dislodgement or disconnection of the ossicles from the So again, this is the area of the posterior area. While you will feel along the vertical facial nerve. So these are all parts. So this is the part actually canaloplasty I showed in my lab surgery. So in a conclusion, I must mention actually that during temporal bone dissection, give you full avoid any distractions like mobile phones. That means I mean to say today who will dissect the bone, their mobile must be switched off, or you can keep your mobile silent, and every 1 hour or 2 hours you can check whether any emergency call is there. You will receive your phone, you will go for dissection, remove your gloves, you will out of the dissection, that will not be allowed. And we will warn you again and again, if it happens in your dissection, we will disqualify it. So it's very important. Any distraction will not be accepted. The most important thing is to find out an experienced, knowledgeable otologist. Yes, get honest advice about your temporal dissection. That means we are there with our knowledge. So it is your duty to show you bones where you have done the wrong, and we will try to correct it. Finally, the hurtful instructions will be the drill, observe otologic surgery, drill, and perform progressively more difficult otologic surgical tasks, and drill, drill, and drill. Thank you all for patient hearing. This is the picture. If someone can dissect very well in a cadaveric bone, this is the cadaveric bone, this is not live surgery, and you can achieve. And you can demonstrate, and you can find out everything like this. This is the beauty of the temporal bone dissection. Thank you again for patient hearing.
Thank you, Dr. Anisur, for his nice initial anatomical presentation, and most importantly, I say, he told about the procedure for